Good afternoon. I'll be presenting on comparison of clinical outcomes of Eyecryl toric and Alcon toric IOLs in a real-world setting. I have no financial interests. Coming to the introduction, nearly 40% of cataractus patients have been shown to have more than one diopter of corneal astigmatism. There are multiple treatment options for corneal astigmatism, such as spectacles or contact lenses, PRK or LASIK, limbal relaxing incisions, or phakic or pseudophakic IOLs. Pseudophakic IOLs have shown to be effective, safe, and predictable. Their drawbacks include incorrect evaluation, marking errors, and post-op instability of the IOL. Our current study is to determine the efficacy of an Indian-produced toric IOL, Eyecryl, and versus that of an international toric IOL, Acrosoft. This table shows us the differences between the characteristics. The important ones are both toric IOLs use a hydrophobic acrylic material, and both have a 360-degree square edge design. The haptic designs are different, and their cylinder power ranges from 1 diopter to 6 diopters with 0.5 steps. But only clinically they correct up to 4 diopters of power. Coming to the methodology, it was set in a single center, single surgeon in South India. The inclusion criteria were all patients who underwent toric IOL implantation, Acrosoft or Eyecryl. The exclusion criteria was any patient with less than 1 month of follow-up, any history of corneal, retinal, optic nerve, or amblyopia, irregular corneal astigmatism, previous corneal procedures, or any intra-op or post-op complications not related to the IOL design. Coming to the IOL formula, SRKT formula was used. The target refraction was a myopic shift of up to 0.5 diopters, and surgeon-induced astigmatism was 0.5 diopters based on his previous surgeries. Online calculators for Alcon and Eyecryl were respectively used. Coming to the surgical procedure, marking pen and bubble marker were used in a straight head gaze to prevent cyclotorsion. All patients routinely received a peribulbar anesthesia block, a 2.58 mm temporal incision, 5.5 mm rhexis, and hydroimplantation was used as retained OVD is a cause for post-op instability, and routine post-op care was given. This is the pre-op characteristics of both the groups. Age was shown to be statistically insignificant, and the refractive astigmatism for the Alcon group was shown to be 2 diopters pre-op and 1.7 diopters in the Eyecryl group, which was statistically significant. All these characteristics were calculated on a Lenstar 900. Coming to the 1 month post-op values, the UCVA was, the uncorrected visual acuity was similar between both the patients. It's given in logmar here. It's 6.9 in both the groups. The post-op BCVA, best corrected visual acuity, was nearly 6.6 in both eyes. It's statistically significant here, but clinically it's nearly 6.6 in both the groups. The corneal astigmatism showed a significant reduction in both the groups, with 0.5 diopters residual in Alcon and 0.36 diopters residual in Eyecryl. It was statistically insignificant. These charts now show the reduction in the pre-op versus the post-op corneal astigmatism. And this chart shows the pre-op BCVA versus the post-op UCVA from around 618 to 624 in the pre-op versus to 6.9 in the post-op. The post-op UCVA to the BCVA is now shown here. This chart shows the post-op UCVA in Snellen's charting. It shows that the majority of patients had 6.6 or 6.9 vision, and only a few percentage had 6.12 or worse vision. Coming to the limitations of our study, it was a retrospective study with a short follow-up of only 1 month. No IOL rotation stability evaluation was done at 1 month. There was no vector analysis, contrast sensitivity was not assessed, and there was no subjective questionnaire analysis done at the end of the post. Coming to the conclusion, both the toric IOLs have shown equally comparable alternatives. Eyecryl toric IOL is a customized low to high astigmatism correction, has shown similar effective functional and anatomical outcomes to the international ones. They also come at a lower cost, that is approximately a third of the international toric IOL cost. So it's shown to have a good cost-effective alternative for less affordable patients who cannot afford the higher priced one. Thank you.
Doctor, did you find any difference of the marks? Because in the imported one, there are 3 dots that are placed peripherally. And in that case of the Indian group, there is a single line which are placed more centrally. So in the final alignment,
Yeah.
what is your opinion if the pupil comes down?
Yeah.
Did you get any advantage in?
The operating surgeon felt that there was both were similar in the alignment and the post-op effect. He did not have a problem.